Welcome, everyone, to the webinar today hosted by the Western Regional Alliance for Pediatric Emergency Management. My name is Chris McCarthy. I'll be the host for today's event. We have three speakers today talking to you about the Arizona REACH program. We have Charlie, Aaron, and Lisa. And Charlie, I'd like to invite you up to introduce your group and take it away. Thank you.
Great, thank you, everybody. Thanks for joining. As mentioned, my name is Charlie Larson. I am a nurse by background and the executive director for the Arizona REACH program, one of two. With me also is Aaron Tams, who is my partner and executive director for Arizona REACH. And then we've got Dr. Lisa Villarroel, who's the chief medical officer for Arizona Department of Health. So I wanted to start off by just saying thank you. Thank you to RAPM for allowing us to share our wonderful program, we think. Wonderful, and want to thank the Arizona Department of Health Services for support of our program as it's grown back in 2020, what it was until what it is today. Phoenix Area Indian Health Services, who has engaged with us directly to expand the program into a tribal support as well, and then to all of you for what you do and for joining this webinar to learn a little bit more. And there we go. Sorry, froze for a second. Session objectives. So by the end of this discussion, our hope is that you're able to take away on explaining how centralized coordination hubs like the Arizona REACH program offer transfer efficiency, particularly for rural hospitals, critical access hospitals, and tribally run hospitals, and also simultaneously preparing for statewide emergency management. Analyze the operational challenges faced by facilities without an infrastructure like this in place, and ideally design a high-level framework for coordination model adaptable to y'all's region's needs. So why is this important? Why does this matter? And why is it a big deal? It's kind of got three prongs here. So we've got clinical, operational, and financial. First, and I think foremost from a clinical perspective, our program is able to handle patient surges through our mission control. We decrease time to care and ultimately improve patient outcomes. From an operational perspective, one of our primary goals of our program is to reduce the administrative burden that's currently or previously for our program did reside with the emergency department teams as they try to manage the clinical acuity of their emergency department along with the operational and administrative needs of transferring a patient. It improves care team satisfaction and retention, which obviously important in the rural parts of the country as well. And then, as we're here to talk about a little bit today, the emergency management piece. Financially, we decrease the total cost of care, and we're very proud to say that this program, the way it's structured for us in Arizona, is free to the hospitals that utilize it. So before we get too far, I just want to talk a little bit about what is emission control. Perhaps all of you know, but there are quite a few ways to create and maybe dissect these things, and so it really does depend on the problem you're trying to solve. But I want to set the stage that we all have this common understanding. So when you may hear it called mission control, you might hear it called a command center, maybe an operations hub. They really all mean the same thing, regardless of what moniker is used. At its core, a mission control, it's a centralized coordination hub. It's a place where real-time information comes together to support smarter and faster and ultimately safer decisions about patient care movement. I really like the analogy in the graphic here to the right of the screen of an air traffic control tower. It's a pretty good mental model. It's not necessarily doing the flying of the planes, but it's tracking. It's tracking all the activity, managing the flow, and helping avoid chaos in the system. In healthcare, a mission control brings together bed capacity, transport status, transfer requests, clinical needs, all into one place. And it provides a single source of truth. So you don't have, 10 people making 10 different calls and getting 10 different answers and trying to coordinate all of that. So, can you land a plane without air traffic control? Probably. Is it safe or a good idea? Probably not. And that's kind of, again, what we like to line up with as I try to describe this in healthcare. I don't think I need to explain any of you for rural and tribal facilities is especially critical. Many of these hospitals operate with limited specialty care, minimal inpatient capacity, staff who literally wear every hat. We talk about that emergency doctor who's also the inpatient doctor, who's also IT and facilities if it's whatever's needed. And they wear all those hats. And so the burden of coordination falls on these bedside care teams. And what Arizona REACH does is it takes that burden off of the front line. We centralize the work of finding open beds and coordinating with receiving hospitals. Again, we're not actually moving the patients from A to B. We find the location, find the bed, find the doctor, find the nurse, help coordinate all of that. So that way the care team in the emergency departments can focus on caring for the patient. So it's not just about logistics though. It's about equity also. A mission control model helps ensure that a patient in perhaps, for our case, a remote corner of Navajo Nation has the same access to care as someone who's perhaps living in downtown Phoenix or Tucson. So when I say mission control, we're talking about building the infrastructure that underserved hospitals deserve. One that supports providers, speeds up care, and helps the entire system function more fairly and move efficiently. There we go. So a little bit more getting into the specifics of the Arizona REACH program. Our program was birthed out of the Arizona Surge Line. The Arizona Surge Line stood up in 2020, and that program was meant to load balance the COVID-infected patients across the state so that we didn't have one hospital overwhelmed with patients while another one had rooms and beds and nurses to care for them and just didn't know it. And so that program ran from 2020 to 2022, very successful, 12,000 transfers over the course of those couple of years. And then as the pandemic subsided and the pressure, I guess I would say a little bit from COVID specifically, started to decrease, the state emergency order ended, and so did the funding for the program. So as we were starting to communicate this to the hospitals that used us, and that program was available to all hospitals statewide, as we were communicating this to them and saying, hey, we're going to be closing down now, there was a lot of white flags waved, and people were like, hold on a minute, just because maybe COVID's pressure isn't here, the results of it are. And we would argue that, even though, well, I guess we would argue that it's harder to transfer patients today than it was even during COVID. And that was due to the staffing shortages that we still experience, but definitely experienced right after COVID. So we looked at the data that we had from the pandemic and realized that of those 12,000 transfers that we did in the surge line, 85% of them came from these rural parts of the state. And so we said, okay, well, they still need some support. And as such was birthed the Arizona Resource Equity and Access Coordination Hub. It's a mouthful, but AZ REACH, as we call it. And now this program supports those hospitals, those tribal, critical access, and Indian Health Service facilities to transfer all of their patients if they need it. It's a voluntary service, but available to all of them 24/7. So we coordinate acute medical care transfers out of these hospitals, streamlining calls for placement, connecting physicians, follow through on placement progress, and really ultimately decreasing the amount of time it takes to transfer those patients. It allows those referring facility team members, those care team members, to focus on bedside care. We provide those hospitals with comprehensive reporting on their patient transfers and any unmet needs that they experience. So primary difference between the two, where the surge line, it was, first of all, it was mandatory, required by executive order of the governor at the time, to be used for any patient transfers related to COVID. And it was for COVID only. And the primary purpose of the surge line was load balancing. Whereas the Arizona REACH program, it's a voluntary service available to these hospitals. Its primary purpose is to reduce the administrative burden and reduce the time to care for these patients, but reduce the administrative burden for the emergency care team. And it's voluntary and available to only that subset of hospitals. So some distinct differences between the two. However, the program is set up to be able to activate in the surge line protocols in the event of an emergency, in any sort of mass casualty incident, pandemic again, or maybe that we have a pretty good seasonal flu season here. And so if anything ever starts to overwhelm hospitals, we are able to activate under the surge line protocols and quickly be available to help balance these patients across the state. So then getting over to the benefits of the program, I'm going to hand it over to Dr. Villarreal.
Yeah, thanks. Hi, everyone. Good morning again. Lisa Villarreal. I'm the Chief Medical Officer for Public Health over here at Arizona Department of Health Services. I'm also the departmental lead for AZ REACH, and AZ REACH is a favorite project of mine to collaborate with, so I'm happy to present on some of the benefits. First, let's talk about the sending hospitals, the ones who are calling AZ REACH. Basically, it comes down to the fact that it's one call. And the busy work of transferring a patient all gets centralized to Charlie and Aaron's group. So all of the calling and being put on hold and giving the basic, patient information and trying a second, a third, or a 10th hospital, depending on the situation in the state at the time, it is just one called AZ Reach. And as Charlie mentioned, it gets providers back to the bedside and off of the phone. Anecdotally, I think Charlie was kind of touching on this too, that we hear that rural clinicians kind of point to managing transfers as a terrible part of their job. And so we're happy to be able to help them with that. And of course, we think the service is of particular help to the locums providers out there who may not know where the system usually sends patients, and if they're doing locums at different hospital settings, it's still just the same number and the same call to transfer a patient out. Also listed on here is the data. The data is great. And all hospitals are given their own facility-specific data of who they're moving out, for what reason, for what level of care, how long did it take to going to what hospital system, and so on. Secondly, the benefits to the receiving hospitals. It's the same, general concept, right? They have one point of contact for these 23, 26, however many facilities who are sending them patients. It also, by having the system, it guarantees that several hospitals are working or working on a transfer of a particular patient if that patient has indeed found a bed somewhere else. So any other facilities, if they were called, let's say at the same time, that doesn't happen that often, but let's say it does happen, then they're notified as soon as that patient has found a bed and they can stop working that particular transfer. Just like the sending hospitals, receiving hospitals also receive data on who they've accepted, for what reason, from where, and what time frame. Third benefit, Charlie, you can go to the next slide, is for public health. Charlie mentioned that we had the surge line. We stood that up in Arizona, kind of making it up as we went. And I can tell you that from the public health side, we were completely unprepared for the sheer real-time reliability and relevance of the data that the Arizona surge line provided to us at the state health department. But so after that, we knew that the data coming out of AZ Reach would be hugely helpful. First off, it's real time. The health department, by the way, does call AZ Reach for situational awareness. Let's say if there's a border crisis, we want to know what the southern hospitals are seeing. If there's weather problems, let's say up north, what's happening? Are transfers just sitting around? Are they still able to move? And so on. We can run rumors or hearsay to ground pretty instantly. So let's say we hear that a particular hospital system is closed to transfers. AZ Reach can see it because they're calling hospital systems, that particular hospital system, every hour, and can address that with fact. If we hear, for example, that a particular hospital is having a hard time transferring out, AZ Reach can put numbers to that and show if that's true and where, quantify it, and identify which systems are struggling the most. We do find, and this sounds a little blasphemous, especially if there are other data folks on the line, but we find that this transfer data is better than the bed visibility data. All state health departments, I don't know if state health is on here as well, but all state health departments, I'm sure have bed visibility of some kind through some program, be it Javari or whatever it is. But the bed data, as we all know from the pandemic, is challenging because different beds are coded differently, and you don't know if they're staffed beds or not, and you don't know if they're holding some beds for surgeries. And in Arizona, we certainly feel at the health department that it is much more patient-centric to focus on the ability to transfer a patient and get them the bed and the care that they need, rather than looking at a spreadsheet that says a particular system has 100 beds available. But if we can get no one into that system, for the past 72 hours, well, then I'm not sure how helpful it is that, they say that the system says that there's 100 available beds in that particular facility. Beyond the data, I think Charlie mentioned this. I'll finish up on this slide real quick about how we have used AZ Reach, and it's built also for emergency response. ADHS, the health department, did emergently expand the scope of AZ Reach's operation for the triple-demic respiratory season of 2022 to 2023, opening it up to pediatric transfers beyond just those coming from critical access tribally operated or IHS hospitals. AZ Reach was also part of, I thought there was two, but maybe it's only listed here, one evacuation protocol for a hospital that was experiencing, I actually don't remember, I think it was water or electrical problems, and AZ Reach was there helping transfer those patients out. And AZ Reach, as Charlie mentioned, is ready to turn on load leveling on a dime in case there's a sudden surge, or even if it's not sudden and we see it coming. So in case of emergency, yeah, we can start load leveling procedures like we did during the surge line, which we found to be hugely beneficial. We were close once with AZ Reach, and I feel like it was the triple-demic, but there was one time where we thought maybe we should go ahead and start that up. We haven't though yet to date, but it's ready to go. I think that's it for me, Charlie. Oh, no, I have one more. Okay, so this is a slide listing out the facilities that are eligible to utilize AZ Reach for medical transfers. So it's the IHS hospitals, critical access hospitals, and tribally operated hospitals. On the left, so that's the list on the right. On the left is a map with those facilities numbered on top of Arizona's Area Deprivation Index, which is this mapping tool that displays the relative socioeconomic conditions of neighborhoods or particular regions based on income and education and employment and housing. And the darkest red regions are the areas experiencing the highest levels of disadvantage. And you can see that's exactly where these hospitals are that we're servicing. All right, now I think that's it.
All right, if it's me. So Arizona's Reach is scope. And people have already mentioned this, we facilitate any medical transfer from one of our participating hospitals. It can be for any reason. That's for higher level of care. The specialty is not available in that originating hospital. Maybe continuity of care is at a different site. Any reason at all, just give us a call and we will move that patient. As Lisa indicated, public health emergency response we are available for. We do need to be activated by the Department of Health for those responses. We also started helping with physician consultations when there's no intent to transfer. And so this can be if you have a patient in the emergency room or in your hospital, you just need some advice on treatment of care. Maybe you can send the patient home. You're not sure. You don't think they need to transfer. We've mapped in our system where physicians are willing to do those consultations, and we started facilitating that shortly after launching. And then we track transportation. We don't facilitate transportation, but we track to make sure the patient has departed that facility, and then we track the time that it took so we can report on that. Out of scope currently is those non-medical transfers. So if there's a patient needing behavioral health or post-acute placement, we can't currently help with them. We also don't help facilitate outpatient referrals and secure those specialists. And while we do get some calls from non-participating hospitals or non-eligible hospitals, sometimes they sneak through and we help them, but we were not supposed to, so we can't help them. Next slide. On the left-hand side is what the transfer process before AZ Reach, or if you don't have access to AZ Reach, currently looks like. It is a jumbled mess of charting on paper, charting in your electronic record that's not really intended to track patient transfer information, phone calls, faxes, very chaotic. And we're hoping to make that a little bit more manageable. We have our transportation, the consults, all kind of flowing together to help make that a little more seamless. Next slide. This is one of our visibility tools. So when we first chart the patient, their age, what level of care that they're looking for, the specialty or specialties that might be required for taking care of them, it will pull up the closest capable hospital system from the referring location. So it looks at that geography, and then it lists them out for our agents to say hospital system A, B, C, goes down a list. This allows us to find that closest one. We do also have a way to target if someone wants to go to a specific region, we can put that in here too. So it doesn't just go to closest, it can also go to a different region. Sometimes there's family or care networks outside of where they currently are. Next slide. This is that bed visibility view that's been mentioned. Instead of looking at those physical beds that might not be ready to take a patient, we look at how quickly patients are being accepted by organization over the last 24 hours. We break that down by level of care. This is just an example, so some of these numbers might not make sense, but it tells us how many patients are currently holding for an organization. It tells us if there are, declined patients, how many they've accepted in that last day. And then it gives us just better direction on if a patient is moving within 225 minutes to med-surg, or if they're going to 87 minutes. If that patient's criticality demands they get placed quicker, that referring provider can make a decision to try a different organization. And next slide. This is some of our program's aggregate data. This is actually on our website that's down there at the bottom. So this is our public information. We post quarterly reports and our year-to-date reports. Transfer outcomes, as of the end of September, we had facilitated over 19,000 requests, and we've transferred over 17,000 patients. It's about 90% that are accepted once they're called to move. Those 10% that don't get transferred, about 50% of them actually end in a physician consultation. So we feel that some of these are patients that did not need to transfer, so we're able to stop those unnecessary transfers and have the patient discharge home or be treated in place. The median time that it takes us to secure placement, that's from the first time they call our program until we are able to get a bed assignment released to that facility. It takes about 1.5 hours, and you can see by region it varies a little bit. Our northern region, it takes about 1.7 hours to find a bed, and then our western region, it's taking about 1.1 hours. Median time to depart. So that's once we give them a bed until they can leave that facility, that's when we're tracking that transportation departure time. It's taking about 1.6 hours on a median for patients to leave. And then we've grabbed that whole bucket. So once they first call the REACH program until the patient is able to depart, we're calling that their ED hold time. I know that that's a small time that they're being held. There's usually a little bit more time in here. So we feel like this is the least amount of time. It's generally larger. That's 3.3 hours on median, and in the north, it's about 4. So you can see that discrepancy between our regions. Median number of attempts. So as Lisa mentioned, we usually try and have one organization working on that transfer attempt, but we do have sometimes where they don't have capacity, so we'll start a transfer with another place. The average or the median is 3. Usually it's about 2 in 3 of the regions. And the max number of organizations we have attempted to transfer a patient is 31. That's actually happened, I think, 2 or 3 times since we've been running. And we also track how often patients are able to stay within the region. So in our central region, which has Phoenix, generally about 93 to 98% of the patients are able to remain in the region. But when you look at our northern and western regions, most of the patients are actually flowing out into the southern and central parts of the state for placement. Next slide, please. This is our median transfer times broken down a little bit more granularly into adults versus peds, our level of care. It still rolls up to those same numbers at the bottom with that 1.5 hour median. And then our top 5 requested specialties or patients that need to transfer are cardiology, GI, general surgery, pulmonology, and neurology. We actually see pulmonology hop up to number 2, number 3, sometimes number 1 during respiratory season. So it's fun to see, fun to see how those different illnesses are floating around the communities. Next slide. We recently sent out our 2025 satisfaction survey to our participating hospitals, and results were very favorable, which we love to see. Got some great feedback about how essential the service is and the support that they're receiving. We also do road trips around to actually go out and see the providers, see the hospitals, and ask for feedback those times, and rarely get negative feedbacks, even though we would love to get them so we can adjust anything that's not working, but so far so good. Next, I think it's back to you. Oh, vision of the future. So we have grand ideas of where this program can do and what it can help. We think that transportation, behavioral health, having some kind of telehealth integration to help with those consultations, of course, emergency management. We'd also like to help those patients return home, and we have critical access hospitals we support with swing beds. So how can we better help within that care continuum? And then, of course, post-acute placement, all surrounding our main core services. Thanks.
Okay. So back to me now. I think, I know, shamelessly, part of our reason for presenting you today is to show you how awesome our program is, but more so, we want you guys to, or give you some ideas or some considerations should you want to do something or already have something like this stood up in your areas. So some things to think about when building your own mission control. I say this as a joke, but I very much mean it, that these things are like snowflakes. They really are all different. And I would warn you to focus on the problem you're trying to solve and then build your mission control. So some things throughout the next couple of slides, there's some things that are proposed just for you to consider when you think about the scope or the operations of your program, should you want to do one. Some things you'll need to research and look up and be prepared for, and then some things to brainstorm if there's a couple different options, and get some key stakeholders at a table and discuss and figure out how you want to handle this. But a couple of resources and things that you should think about here. Hospital beds per capita. Of course, I think we all know why that's important. Obviously, the less beds per capita, the more strained the hospitals can get, particularly during any times of surge. So there's some websites out there to find the hospital beds per capita, as well as the facility types to consider. So as we've mentioned a few times, the Arizona REACH program built for critical access, Indian Health Service, and tribal PL 638 hospitals. We chose them because they were the ones that were using us the most and needed the most support as a result of looking at our data from the surge line, but also remembering that there's an economies of scale. There is a staff that staffs this program 24/7, and so you want the program to be busy enough so that you can staff this 24/7 and don't have people sitting around, and that you can make sure you're supporting the most hospitals possible with the right number of staff. So there is that productivity balance there to consider. And so we have found that where we're at right now works, supporting those hospitals and with the scope. But again, depending on the problem you're trying to solve, you can build this in any way that fits your needs. So other things to think about: your local landscape. What is in place today? Is there already something in place, and is it working on evolving, or is there not something in place? What kind of groups are out there? Who owns it? Is it great? What could be better? And thinking about that problem you're trying to solve, a pretty simple exercise is to think about and brainstorm with a group of key stakeholders, particularly if you're thinking about something rural like what we're doing, is look at the top, have people brainstorm the top 5 or 10 maybe issues or challenges that they have when transferring a patient, and then rank them. Well, not rank them. Yeah, I guess rate them, not rank. So you're not ranking them 1 through 10, but rating them. A 1 being it's not that frequent, and a 10 being this happens every time I try to transfer a patient. And then look at the time delay that you experience with each of those. Again, a 1 being not too much of a time delay, but it's there, versus this is a significant time delay. And when you add those up, you'll get yourself some numbers, and it'll tell you pretty clearly, usually pretty clearly, what types of things you should be focusing on. And I just say that, I say over and over again, pick the problem you're trying to solve and focus on it, because as you build these things, as you saw on our previous slide that Aaron was talking about, the future vision of our program, build it and they will come type of thing. So right now we do medical transfers, and we are constantly getting requests for behavioral transfers, for transportation coordination, for all these other things. And if you don't have a good focus on what it is you're trying to solve, the problem you're trying to solve, those things can get very distracting and cloud your program. So I would say to focus on things early, build your program for that, and then get to expansion, which is why I say that often to find your problem. Who are your execution partners, and who's your champion? Thankfully, for us at Arizona REACH, we've got someone like Dr. Vera Well to be our champion, and has been instrumental in the program getting to where it is today. So that's our public health allies. There's private allies too. We do have to work with the private health systems. And so what does that look like? And find somebody there to work with you and help build this. Local associations, content experts, people who know Transfer Center, et cetera. All those folks will need to be a part of your team and the execution partners. Who's going to staff your coordination center? Again, thinking about your problem to be solved, does it have to be clinical staff? An interesting note is that Arizona REACH is staffed primarily with non-clinicians. We don't make medical decisions. We help with the coordination and releasing the administrative burden, making those phone calls so that the doctor can get off the phone, or the CNA or the HUC or whoever it is in the ED can get off the phone and instead care for patients. So we found that we don't necessarily need nurses in our transfer center. Many hospital system-based transfer centers do require nurses for different reasons. And again, it all depends on what the scope of their team and the function of their program is. So think about those things. Of course, obviously, if you can get away from the clinicians, it makes it a little bit cheaper. Technology and data. So what systems are in place today for bed capacity? Dr. Well talked earlier about Juvari or whatever other programs that most every state has. What is your HIE? What other data systems are out there? Or most frequently used EMRs. Currently, we function without any direct integration with anybody, but it is something that if the folks are willing to, it certainly could be beneficial for you. Again, think about how you want to build your program with that. But if there's a common EMR that's used, perhaps there's some integration opportunities there. And then data. Think about if you have a program in place today, or even if you don't, what data do you have around transfers and what do you wish you had? And keep that in mind when you build the scope and the function of your program. Geographic boundaries. So Arizona reach is right now confined to Arizona. And so those are the state lines outline the folks who can use our program. Although we transfer across state lines, the people who can call us all reside within Arizona, but it doesn't have to be that way. In fact, I think a learning from our surge line operations was that it probably shouldn't operate that way. So can you get a group of states together, as there's many transfer patterns, particularly for those hospitals that live near the borders of states, and their regular transfer pattern may be to the largest city in the state next door. Make sure you're thinking about those things. So you could do a geographic boundary of a state lines. You could do a region within a state even, or a group of states. Do you do a hospital type? For those of us, or those of you that are involved in the tribal healthcare, is it maybe tribe specific, et cetera? And then you think about, when should the hub be activated? There are a couple of programs like ours out there, where ours today operates as a primary referral pathway. The physician can pick up the phone and call us and make us, and we encourage them to make us their first phone call when they need to transfer a patient. However, there are operations out there, for example, up in Oregon, that their program is built in a way that the hospitals should try their normal transfer patterns first, and in the event that those fail, then they quote unquote activate the hub. And the hub is meant to be like a source of escalation, where ours is meant to be just a primary pathway. Again, depending on how you build it, very much differentiates how you do that. Clinical boundaries. So our program operates for medical only, but also other things to consider: behavioral, non-emergent, post-acute, et cetera. Those other things that we've been requested to expand to. Do you do just adults, maybe just a pediatrics? Our program is available to ED patients as well as inpatient transfers. Or maybe it's just by a service line or a specialty, something like just COVID. Maybe you do just ICU. There were some of those programs that were up during the pandemic, statewide programs that only transferred ICU patients, et cetera. Hours of operations. We do 24/7, 365 all needs. You could do 24/7, 365 for a specific condition, i.e. the COVID program. Or you could maybe perhaps just do it for seasonal surges. I caution that anytime you're not operating as a 24/7, 365 program, then that makes you unavailable to a mass casualty incident response, or quick response to something like the triple-demic, or a hospital evacuation. And so that's why we've chose to operate in the way in which we do. I will say, and I would caution, that normal business hours, like, is there any normal business hours in healthcare? But the Monday through Friday, 9 to 5 type thing doesn't work, in particular because when you're doing medically urgent or emergent transfers, as we do, sometimes those transfers take a little bit of time. And so if you were to take, for example, taking a call right before you're supposed to close, then what? You have to hand that back off, and that gets pretty messy, or would get pretty messy. So I would encourage 24/7, 365, however it is that you decide to operate. Funding. I am going to hand this over to Dr. Viruel a little bit. Our program is funded what we call braided funding, or what everybody calls braided funding, with a couple of different sources to fund our program. But Dr. Viruel has been most involved in helping this program stay afloat financially. So I will hand it over to you.
Yeah, thanks, Charlie. Also, real quick, based on what you were just presenting on, to everyone whose region is considering a system like this, please, sorry, Charlie and Aaron, but please reach out to Charlie and Aaron. They are absolutely the experts. They didn't say this, but they came from a major transfer center, and then they came and set up and ran the Arizona Surge Line, and then they came and set up and then now currently run AZ Reach. They've set up another state's control center. They've analyzed and consulted with multiple other states to help brainstorm how to set up a system in their state. Take home message, grab their emails at the end. That's definitely who I would consult with. Okay, back to the slide and the funding. The populations that benefit from AZ Reach are multiple. And since the cost, I don't know if it's in here, you guys, but the cost, is $2 million plus-ish. I think that's hard for any one organization to shoulder, especially, to get massive help from public institutions right now. It's just not going to happen. And since the beginning, like Charlie said, we've been braiding together our funding, shifting a little bit each year. Public health has really come through to fund most of it, whether it's through ARPA funds or healthcare disparities or hospital preparedness. I think maybe some COVID funding as well. State budget has kicked in, I think, twice now with some funds, and we have some federal agencies who have kicked in some funds as well, which has been hugely helpful. Sustainably speaking and moving forward, it'd be great to get the payers on board. That's a tricky thing proven to us so far to pull off. We'd also love to have a reliable budget in the state legislature as well. And ideally, frankly, we would like more than that 2 million so that we can expand to what Charlie and Aaron have mentioned this whole time, that people, frankly, that the hospitals have been asking for since Surgeline in 2020, which is, can you please expand to behavioral health and to transport coordination and to more hospitals rather than just these 23, 26 that are currently eligible. We'd love to do all that. This team is ready to do all that. It's just we need more funding and not just year by year. Charlie, did you have any more on this?
No, I think that's it. Thank you. So a little bit of reflection and next steps. Sustaining the work. Sustainability has been the biggest challenge, of course, finding the funding year over year. So transition from startup and project dollars into stable funding streams, diversifying, like Dr. Viola was mentioning, through all those different opportunities for funding, emphasizing the ROI being the cost avoidance, fewer unnecessary transfers, reduced length of stay, retained revenue within those tribal and or rural hospitals, able to keep patients at home. And is why we do believe that helping transfer those patients back is one of our first expansions that we need to take over, and helping coordinate some of that. Infrastructure and advocacy is obviously vital to the sustaining of our program. Advocating for mission control as a critical public health infrastructure, integrating with state emergency preparedness. That's really gotten a lot of traction lately for us in Arizona, is getting involved in those statewide plans for when there is an issue and patients need to be dispersed at a rapid pace to get not overwhelm just one or two hospitals. And then pushing for legislative and policy support, budget line items, statutory recognition, et cetera. A couple of things that we wish we knew from the start. I'll say, as I mentioned at the very beginning, like I didn't say these words, but no good deed goes unpunished. I would say the demand is higher than you should expect. And if it's not the immediate demand, it'll be the demand for expansion shortly thereafter. So the daily transfer volume, there you go. Daily transfer volume, demand for data, demand for expansion, those types of things is there from day one. The data, I'd say the data is important, and I think we all knew that, but there's always kind of this trust but verify. We are bringing competitors together as collaborators to some degree in this. Now, very much so when the Surgeline was running, but some degree even in the REACH program today, bringing these folks together. And so you definitely need to have the data to verify that you're not impacting any business operations. And we work very hard to make sure that our program and the decisions that are made around transferring a patient, that we don't influence we don't make those decisions, and we certainly don't change a decision, especially if there's a business relationship in place. We're there to take the administrative burden and operate as if we were the physician or the ED clinician or staff member that's calling us. We're operating as if we were them and doing exactly that. Now we have those tools to be able to see where's the closest facility and how well our facility is doing, A versus B versus C at taking a certain kind of patient. And that is just to give that physician who is calling us that knowledge so that they can ultimately make that decision on where they want to send the patient. And then we operate under those directions. So there's a lot of trust but verify, and you can do that with data. You can only operate at the speed of trust. And so I'd say building trust is something that, we always knew from the start, but of course the importance of it, I can't emphasize enough. Establishing an advisory council and governance council early, making sure that there's a well-defined decision structure tree on who has final say, whether it's an expansion or some sort of operations request or challenge that we're experiencing. Someone has to be able to be the one that says, this is what we're going to do. And then, of course, sustainability, communications the trickle-down communications like you want always to work, it won't. And so, you can't over-communicate enough. And then the manual work effort is greater than planned for. As much as we have programs in place, our program in place and technology in place to help reduce the manual lift, things like phone calls, faxes. Unfortunately, we still rely on fax machines, and we still rely on those. And we try to get away from those, but especially early, plan on things like that to be a requirement. And I think that is all we wanted to share. Yep. So these are our emails. So azreach@blackboxhs.com. That reaches our entire leadership team. We all monitor that inbox. Otherwise, you've got myself or Aaron specifically, and then from an oversight or a medical perspective, Dr. Vera email there is at the bottom. And so I'm going to stop sharing and then allow for any questions.
Yeah, thank you, Charlie, Aaron, and Lisa. That was a ton of information. And I already had a request to share the slides within the first couple of minutes. So yes, the answer is for the participants today, we will be sharing a PDF of the slides as well as a recording. So we're going to jump into the questions. I've got 4 questions out here that are still open and unanswered. I'm just going to go in order. How often are you requesting your hospital's update bed count? Is this automatically fed to your dashboard from different EHR systems?
I can take that. So we don't ask for bed counts. We haven't been using it since the surge line stopped, and that was just because we did not find it as beneficial to know that a certain hospital had 5 or 10 beds, just because not every bed can accommodate every patient. And so we started using our operational data to see where patients were being accepted and try from there. So there's no feed.
Yeah, so if I can emphasize that, it's a ghost we've been chasing since our time when we were working at one of the major health systems is these ADT feeds that show, there's this many licensed beds and this many heads in beds, which, the delta is how many you have available. And as Dr. Vera was mentioning earlier, it may say there's 10 beds available, but 5 of them are closed for maintenance, 2 are closed for staffing, and really there's only 3 available. And even then, depending on the hospital, we found that the system that we worked for had many hospitals, and there was the really large hospital that was kind of the flagship hospital of the system. And that place could be operating at 100% capacity, 105% capacity, and they were still taking patients from us in the transfer center because they had so many resources around them, and the flexibility and the ability to move nurses and patients, et cetera. They could always take patients. Whereas the 100-bed hospital would get down to 3, 4, 5 open beds, and that was it. They were done taking patients. And so we just find more value in, not that I don't care, but I don't care how many beds you have, how fast can you take the patient? And so all of that dashboard or that bedboard that we showed earlier, that Aaron was showing, it's all built on our own data on the last 24 hours of operations. How fast are you able to take patients? How often are you saying yes? How often are you saying no, et cetera? So that we can then look at, regardless of how many beds you have, operationally, how quickly are you taking patients? And that's what we found to be much more valuable to us. Of course, there would be value to also see the beds. It's just much more of a lift, and you get to anytime there's a manual requirement for something, it's probably not going to happen. And so we've just avoided it.
All right. Sounds like that was a welcome response. So yeah, thank you both on that. Next question I have, it was noticed that Tucson ER and Hospital as one of the sending hospitals on the list. We don't believe it's rural, critical access, etc. Would you please address its inclusion on the list of sending?
Did we talk about STEP in here?
Yeah, okay. Right over it, yeah.
So a couple of times we have been given funding from the state legislator to open up to hospitals with 20 or less beds. And so that's happened twice, and they have 20 or less beds. Actually, they are the only hospital that has not used our service. And it's a kind of thorn in my side because we have 100% participation from all of the hospitals except theirs. So they haven't used us. And when we met with them, they are located in the heart of Tucson, which is one of the hubs for our medical beds. So they don't need us very often, obviously.
Great. Next question we have, what would be your role in medical transportation for a highly infectious disease patient requiring specialized units?
You want me to take that, Aaron? I can at least start it, and you can fact check me and help me with some. So regardless of the patient type, when we take an intake of a patient, we'll get all the demographic information on them, as well as from the sending provider, what type of specialty care, meaning infectious disease, cardiology, nephrology, et cetera, et cetera. We'll get all of that information. And then we find from that sending physician, where do you think this patient needs to go? Meaning, do you think they need ICU? Do you think they need telemetry? Do you think they need medical? And then we will ask if there's an isolation requirement. So we take all of that information. Now, with that bed visit, the first tool that we had that showed the closest hospitals and how many miles they were, when we put that information in, infectious disease, nephrology, neurology, and ICU. It will only bring up hospitals that have those things. So we in the background as a leadership team, we met with all of the accepting facilities in the state and in the region, New Mexico, Nevada, Utah, Southern California, and found out what type of specialties they have, and do they have it on call always? Do they have it intermittently available, or are they not available? And we build all that into our program so that it can answer those questions for us when we enter in the patient information. It tells us what places are available. So regardless of how specialized or how critical a patient may be, we enter in that information, and our tools tell us what hospitals have it, and ultimately we will end up calling them to ensure that they now have a bed. So we may call and say, we need these things. We show that you're available. Do you actually have the bed? And do you have an isolation bed for this type of, for this example? And in which case they would say yes, no, or otherwise, or they'll work on it, kind of thing. And that's where we get into our follow-up protocols. We would get back to the sending physician, say, this hospital says they have the beds, but they got to do X, Y, Z. And so we start following up with them. Depending on how critical the patient is, it determines the frequency at which we follow up. And so we would start doing that follow-up with them and start trying to push that transfer. In the event that the patient or the transfer is taking too long, and the determiner of that is the sending physician. In the event that it's taking too long, they can then ask us to seek out other placement options. And in which case we start as close as we can, and we just keep moving that radius out. And when we get to, a certain distance, and we'll call the physician back and say, hey, okay, we're actually looking out of state now, or, we're 300 miles now. Do you want us to keep going outward? And that's where we get into that, those examples where we've called 31 different organizations. And remember, one organization may have 15 hospitals or 10 hospitals or 4 hospitals. So, we're calling that organization, and all of their hospitals have said yes or no. And so that's where we that radius gets pretty big, but it just we'll have that conversation with the referring physician to understand how critical is this patient? Are you willing to hold them? Are we willing to wait for this place? Or do you want us to keep looking? We can go to New York if you need us to, but you tell us what to do.
Kind of still on that, I'd like to take that from a different perspective. Can you talk about the interaction with the transport? And to that end, another one of the questions, advising on EMS involvement in that transfer, again, in the context of we've got a highly specialized or special pathogen or something like that, dealing with that transfer.
Yeah, sorry, I think I get the question. I think the question is more if we're trying to transport an Ebola patient and what's the protocol for that? Yeah, so I can start, Charlie, then you can end it. But basically right now, AZ Reach does not do transport, and we do not do transport coordination. The only thing AZ Reach does is track how long it takes to get that transport there. And we had no role in getting the transport there, no matter if it's a specialized transport or if it's from the CON, whatever it is, we play no role. All we do is write down the time. And so we don't have a protocol yet for what you're asking, because it's not within our scope currently. Now, I wish it were. The hospitals wish it were too. So in the event that we get funding for that, then of course, then we would work with EMS and the state to figure out what is the protocol and a highly infectious, public health importance, Ebola, hemorrhagic fever-ish situation. We're just not currently there. Sorry, Charlie, go ahead.
Oh, that's it. That's a great answer. Our role is to find the bed, find the doctor, get the nurse, get all the handoffs, do all that coordination for them. And then ultimately, whether it's a highly infectious patient or a routine patient transfer, they still organize the transportation, which you can imagine the administrative burden. And with that being our goal is to reduce that for those physicians. Obviously, this is a top priority for us to get the funding to be able to expand that. But so we just monitor it now. So we give them the reports back so that they can then have those conversations with the EMS teams around performance or whatever else it is, if they feel like the data is good, bad, or otherwise. We just give them the data to be able to be armed for having those conversations.
Great. Yeah, thanks for indulging me there and going a little deeper for the questions that we had. Next one I have in the list, do you work with other hospitals not on your list and their transfer centers?
So those are the accepting hospitals. Yes, we work with every hospital for accepting. The sending hospitals are the ones where we're restricted on who can call us, because that's what is actually initiating the work, right? That's what is actually requiring the team is how many hospitals we have calling us, what's their volume, how often are they calling us, et cetera. And so we have the list, the specific designation of hospitals that can call us. We reach out to all hospitals that whoever comes up that has, with our tools that has the services and the specialty provided. So in that example, like, again, that's where, when we call one hospital system that has 5 hospitals in the valley here in Phoenix, when we call their system, we're calling their transfer center. We'll give that, we say, we are calling on behalf of the sending hospital. We are the proxy for them. And then, we'll help connect back for physician to physician conversations, et cetera. But so we definitely work with all of the transfer centers, which is nice, because then when someone gets accepted in one of those cases where maybe we've tried more than one location, when someone gets accepted, we can stop the other locations from working it. We've been on that end, on the major receiving side, where we get a patient accepted, or we've accepted a patient. Now we finally found a bed. It took us a couple hours to do that because of XYZ. We call that sending hospital back, and we're like, we're celebrating. We've got you a bed. Here's the number. And they're like, oh, this patient left an hour and a half ago, or was accepted an hour and a half ago. You can cancel that. And it was like, oh, well, that would have been nice to know before we did all this work. And so we do that for them. So we stop all of that work from happening and clean up what's called the wait list cleanup for them, so they don't keep working it.
Awesome. Just a reminder for our attendees, if you've got any questions, you can still enter them into the Q&A box. So we're down to one. I just saw another second question, so good deal. For clarification, you reached out to hospitals directly to determine specialties available. Was this not obtained via departments of public health, hospital associations, coalitions, et cetera?
We reached out to the hospitals to see the specialties. So we asked what their levels of care were, ICU, PCU, tele, PICU, all of the different levels they could accommodate. And then we had a whole list of specialties by adults and peds, and asked them to say if that was available all the time, sometimes, or never. So we knew when to call. Sometimes they'll say it's not available for a week, and we'll put them on bypass for that service. And then we ask them to update if that changes. It's incredibly hard to find where specialties are available on public sources. So always good to go straight to the source.
When we first started the program, we did so via a survey that was sent out, and it also gave us the opportunity to sort of like announce our presence to these folks, so they knew who was going to be calling them to transfer a patient. So it was kind of a dual purpose. And then we do update with them. Erin, how often do we, do that actual meeting with the accepting facilities?
Say about 6 months, but if they have a big change, they should let us know.
And we find that out on the fly, right? So if we're calling somewhere that normally has cardiology, and we call them and they say, oh, the cardiologist left, we don't have cardiology anymore. I'm using a ridiculous example, but that would be one. Then we go in and update our program so that it stops recommending that place until further notice.
All right. Final question I'm showing here right now. Do only the sending and receiving clinicians and hospitals need to be EMTALA compliant? Is AZ Reach EMTALA compliant, or is it not addressed by EMTALA?
I guess I'd probably have to ask to clarify EMTALA compliant. Certainly, we all operate within the EMTALA guidelines, right? And so if we are targeting a location and they have the service available and the capacity to take the patient, then as such, EMTALA would require them to take the patient. Same way on the sending location, if the patient is not safe to be sent, hasn't received the full medical examination, et cetera, that would be expected before calling us. And so we operate within EMTALA. We are HIPAA compliant and all of those types of things, but I guess I would ask for a clarifying around EMTALA compliant for our program, unless I answered it accidentally.
Give me just a moment. That question came from Dr. Walter. Dr. Walter, I've just promoted you if you'd like to, or he did just say thank you in the Q&A as well. So I think we did get that done. So perfect. All right. I'm going to do one last check here of the text and our Q&A. Final call for questions for this group of superstars. Charlie, Erin, I do see a hand raised actually from Melissa. Melissa, you should be able to come on and ask a question. Thank you.
Great. Thanks so much, Chris. I just want to acknowledge Dr. Royal and Charlie and Lisa. As a fellow resident of Arizona, I very much appreciate learning more detail about what you're doing for our great state. So thank you very much. I have a couple of questions, three in total, and I'll I'll state them rapidly and then turn it back to you to answer them. Do you identify as a MOC, a Medical Operations Coordination Center? As my first question. Second question is, in your transfers, do you identify or help to identify specialty needs such as a pediatric ophthalmologist or pediatric hand surgeon, those rare specialty type needs that come up on occasion? And then lastly, I'm wondering, do you facilitate telemed physician consults when perhaps a transfer is maybe not available, or if that's all they need and the patient could stay in their own community? And with that, I'll turn it over to you. Thank you.
Dr. Vierwald, can I give you the mock question? I think I want to answer that, but I don't want to screw it up.
Yeah, I mean, correct me if you disagree. Melissa, yeah, I think we would identify as a MOC. I think we published, well, I guess we haven't published specifically on AZ Reach yet. No, we definitely identify as a MOC. I think, yeah, I mean, the answer is yes. We're not, and we're not operating under an emergency right now, or anything that requires, this intense level of load leveling or anything of that sort. We just exist as like a baseline service, but able to turn on into emergency mode and load leveling and so on. But my answer is yes.
Okay,
Charlie, I'll pass the other two. Okay.
So I wanted to say also, I just wanted to make sure there wasn't a definition that
No, I think so.
that maybe didn't hit. And I'm sorry, Melissa, unless Aaron, you remember, I'm gonna have to ask you to just remind me of the other question.
That's okay. The second question was, do you help to identify rare specialty needs, such as a pediatric ophthalmologist or a peds hand surgeon, just as examples? And then the one thing I failed to mention earlier too was, I was also wondering about your involvement in supporting trauma and burn patients.
So on the specialty needs question, yes, that was actually kind of, I would say, an unintended benefit when we first started doing all of this mapping and understanding what hospitals have what specialties and what care, et cetera. We were able to identify care deserts. For example, and this isn't a real example, but for example, after we mapped all these hospitals, did you know that in the northeastern 300-mile radius of Arizona, there is 0 cardiologists that practice up there or that are in hospitals. And if any patient has any need, they have to be transferred. So we're able to identify things like that to then, as a public health visibility tool, to give that back to public health, to talk about different legislative opportunities or educational opportunities, or maybe some what's the word I'm looking for? Trying to entice physicians to get out there and practice, to be able to close some of those care gaps that are out there. Yes, I guess we do. That wasn't the intention of it, but we've found. And then also through our data, when we send these weekly reports and then monthly and quarterly and annual reports back to these sending facilities, it has, you transferred out this many cardiology patients, this many neurology, this many nephrology patients, et cetera. You transferred this many patients out that ended up in PCU, or progressive care, cardiology, this many that ended up in ICU, et cetera. So then they can then evaluate their own operations and say, is this something that we should consider? If we had this type of specialty, or if we had this level of care, we would have been able to keep all of these patients. So I probably think it's probably the extent. Aaron, would you add anything to that?
Nope.
Okay.
You also asked about telehealth. So we don't currently have the capability to do any telehealth, but we did start consultation. So if someone is looking for a peds ENT doctor and just for a consultation, we will try and hunt down an ENT to answer those questions so that the kiddo can get the consultation they need without the transfer. ENT is an example of a specialty that's incredibly hard to find. And currently in our system, we only have specialties that are mapped at hospital level. So we wouldn't be able to connect someone with a, ophthalmologist or ENT that's not within the hospital setting. So we would like to be able to help with those outpatient referrals, but it's just something we don't currently have mapped out.
Another one of the things we've been asked for many times. Anything else? Did we answer everything? I think we
answered all of the questions. Thank you very much. And I also just want to just thank you again for including infants and pediatrics in this program as well. I saw NICU and PICU on your spreadsheet, and I just very much appreciate that. Thank you.
Yeah, and I think that was the other question, was our involvement around trauma and burn types of patients. We can and we offer to help with all sorts of acuities, and so we call them the quote unquote life or limb types of transfers. We definitely want to help with those. We recognize, particularly with trauma in these smaller hospitals, they've got very strong relationships with the local trauma centers to take those patients very quickly. We argue that when it goes well, it goes very well. When it goes awry, it goes awry badly. And so, we offer to still help with that. And in the event that it does go awry, and all of a sudden this place that always takes your trauma patient can't for some reason, that we can quickly activate and get the patient moved elsewhere, where, like if the physician is relying on that relationship heavily, they wouldn't be able to. So we do offer help with all sorts: trauma, stroke, STEMI, aortic catastrophe, any of those things we offer our supports for.
Thank you very much. Chris, back to you.
Yeah, thank you. Well, that brings us to a little past the hour and the end of our webinar. So thank you again, Charlie and Aaron and Dr. Villarreal. This was a great talk. I think we got lots out of the Q&A. Again, we will be sharing a recording and these slides through the RAPM website and possibly coming to a social media post near you. Thanks, everyone. Take care.